So I'll just briefly tell you the agenda of the current talk. So what's happened is April 2022 INI SS session gastroenterology part will be discussed in this current talk. First thing. Second, these questions had been recalled before, and of course, it is subject to some changes based on what students were able to recall. There could be some questions which are incomplete, but the sole intention of these questions is to just know what are the topics and how to go about it, and what are the topics that we should probably concentrate on. And you would notice that some of the questions the topics or the same questions may also repeat. Now, I would not be going into detail about the exact theories. I would just go into question and what is the probable answer and why is it the probable answer. Once the entire talk is over, I will be sharing my personal number. You guys, or whoever are already in the WhatsApp group, I would be sharing this particular PDF file that I'm discussing currently. So do not worry about missing out on some important notes and things like that. You would get a complete idea of all the tables that I'll be discussing in this current talk. It will be a little fast session because we're not going to too much theory, and all of you have just exams coming up in a very small time. Okay, so I think it's time to straightly dive into the questions. Later, you guys can keep in touch with us with respect to the link for the particular talk, and it would probably even come in the app for further to go through the videos if you feel like you want it. But the PDF, I will send it to you across in a while. So let me start screen sharing. Yeah. I just want some thumbs up if you guys are able to see the screen that is there in front of you guys. Yes, excellent. So let me straightly dive into the discussion part. So the first question I would want to just talk is: a 3-year-old child swallowed a foreign body. He is completely asymptomatic. Chest X-ray shows 3 centimeter foreign body in the esophagus with a double halo sign. What's the next step? A, wait and watch. Repeat a chest X-ray after 24 hours. This is option 1. Option 2 is urgent upper GI scopy and remove it. Wait for spontaneous passage. And D is urgent surgical referral. So now see, double halo in the esophagus. Any foreign body in the esophagus, you have to remove it when especially it is stuck in the esophagus. Now this is a small picture. You can see the X-ray. You see this double halo. That means this is a button battery. Okay, so you have to remove it urgently because there can be complications with a button battery stuck in the esophagus. The anode and cathode can become a circuit and lead to even perforation and very bad complications. Okay, so this is it. So let's go to next question. A 60-year-old, he has a combination of HBV and HCV. Now, HCV RNA is in lakhs. I'm not sure of the exact number. HBV DNA is 1,000. AST, ALT are in approximate 100. Fibroscan just is within normal range. There is no fibrosis. Okay. Usually remember fibrosis and cirrhosis ranges. More than 15 is cirrhosis. Okay. So there's no fibrosis here. A, symptomatic treatment. B, treat only HCV. C, treat only HBV. D, treat both of them. Now, what would you do in this situation? Now, when such questions come about combined infection, first see whether there is an indication to treat each of them. What we know is HCV is a definitive treatment of usually consisting of 3 months directly acting antivirals. Okay, so this has to be treated because it is curative. Now here there is no indication for treating. But what of late the theory, when we read more on this topic, we get to know that when there is a combination of HBV and HCV, the tendency to have HBV flare is more while treating HCV. Okay. So when HCV is being treated alone, HPV flare can occur. Okay. So what they see is some of the guidelines tell that you start prophylactic anti-HBV therapy, that is tenofovir or entecavir, and parallelly give HCV treatment. But then let's stick to the standard textbook, that is Schlesinger, which says that as still the incidence of the HBV flare, though definitive, is not yet conclusive on major studies, it is better to monitor the patient rather than start HPV. So the answer for this particular question would be, if similar question has been asked and there is no indication that is in the form that DNA is less, right? You just have to do management for HCV. So I would stick with B to stick with Schlesinger. But then if you guys go through some of the topics, I will send the PDF. Do not worry. You see which is dominant in the based on the HCV RNA and HBV DNA levels, and then take a call. That's one thing for co-infections. Okay. Then there are some data which says that based on this you can treat for both of them. But then, yeah, this is a simple chart which tells that you see the values of RNAs and DNAs and then take a call, and then you start initiating treatment. Okay. But then what we have to stick to is this particular lines from Schlesinger, page number 1237, chapter number 79, which says that the optimal treatment for an HBV and HCV co-infected patient often exhibits high HCV viremia and suppressed HBV DNA, okay, or vice versa. So one of it is dominant, one of it is suppressed. Okay, usually what we see is HCV is dominant and HBV is kind of suppressed. Now this is the common pattern that you get to see. Now what they are telling is, now when you have both co-infected, studies from Asia have shown that patients are at highest risk are those who are HBsAg positive and those who have advanced liver fibrosis. Such patients should receive prophylaxis against HBV reactivation when receiving HCV therapy. By contrast, those who are HBsAg negative but anti-HCV positive may be monitored with serum HBV DNA measured at least once during DAA, with initiation of HBV treatment when the HBV DNA levels increases by 1 log. Now, these studies underscore the importance of screening for HBV prior to treatment of HCV infection and the need for monitoring HBV during HCV therapy. So, what they are trying to tell you is, if there are two different lines, I would also come to this is the first, again, mention is legendary in different part. I've mentioned the page number. Now, here, what they say is, when both are infected, now these particular group of patients are at higher risk for getting HBV reactivation. Now, in such patients, especially if these risk factors are there, you can consider prophylaxis. If HBsAg negative but anti-HBC is positive, then you might just monitor. Now, this is where you have to look for these two particular risk factors in that particular patient. But what I would like to say is, in one place, they become very more clear. In the chapter of HCV, chapter number 80 in 1279 page number, what they say is, because the true frequency of HBV reactivation is still unknown, prophylactic antiviral HBV therapy is not recommended, and patients with HBV current or past infection should be monitored during DAA therapy for HCV. Okay, so when you treat for HCV, you just monitor for HBV would be a preferable answer. Okay, however, also note in that particular question if they're also mentioning high risk groups, like what I have just mentioned from the previous slide, that are advanced liver fibrosis and HbA1c positive patient. Just remember that. But then overall, it has been quite clear that it's not recommended to start and you just monitor. So you can mention both as an answer, be clear, but one of the guidelines in this particular thing, it has been given. So what you should know is this is a gray zone. You have some guidelines telling treat both, some telling just treat HCV and monitor for HPV. Now here, there is a clear thing of what your answer should be in this particular lines. Okay, I hope things are clear. If you still have any doubts, let me just come to the chat box. Yeah, I don't think there's any doubts. If there are doubts, please get back to me. I might sometimes skip the chat box at times. Okay, yeah. Let me go to the next question. See, Schilling's test is now never done of late. We have vitamin B levels and we have different, methylmalonic acid levels and things. But for MCQs, this is still a question. The concept of Schilling's is still considered complicated to be tested in your exams. So if Schilling test is positive and patient has a D-xylose test which is negative, what is the probable cause? For this, you should know what is D-xylose test. Now, D-xylose test is where you give oral D-xylose and then check how much of it is excreted. You give it orally, they get absorbed across and then excreted across the kidneys, and you check in the urine. Its level in the urine, if present, it just tells that how good is the surface area of small bowel for absorption. Okay, so this is the main thing that is indicated by D-xylose test. So if a patient has positive Schilling's test and a negative D-xylose test, that means that patient has vitamin B12 deficiency, but the entire surface mucosa or the surface area of small bowel is normal. So what could be the cause? Is it an ileal disease? Extremely likely. Intestinal lymphangiectasias? Wrong. Celiac disease is more of a proximal disease? Wrong. And pancreatic insufficiency, again, there is completely has nothing to do with a D-xylose test in this particular case. Okay, so what you guys have to remember in this part is a positive Schilling's test just means they actually in the question you might have more details more specifically, but this is just a recall where the patient has vitamin B12 which are less. You are finding at what level is the problem present. Okay, now you first give vitamin B12 and then see whether there is correction with each factors. Okay, so just watch for what is the level of absorption problem is there, and then you get to know that in this particular question probably the level is the entire ileum or the terminal ileum per se. Where is the problem? Okay. Also, a positive Schilling's test can be because of small bowel resection and various other causes where the surface area of the bowel is less, because of which the vitamin B12 absorption is reduced. Okay. So the D-xylose test is just mentioned so that you rule out a diffuse small bowel problem. Okay. So that's about it. Say this part is being tested here, whether it is an ileal disease or a resection to differentiate these two. So the answer would be an ileal disease. So next question is, if you guys have simultaneous doubts, please put up in the chat box. Irrespective of DNA Sir, in cirrhosis, they recommend to start nucleotide analogs for HPV irrespective of HBV DNA that's obvious. See, that's what is there. In the question, when they tell you that patient is cirrhotic, you have to start treatment for HBV. I'm not telling that. In this question, from whatever you have told, there is no direct indication to start HBV treatment per se, isn't it? So in that kind of situation, because there is been increase with HBV flare, there were many guidelines which were telling you should treat both. But Schlesinger, what they tell us, because still the prevalence and studies are not very clear on how much it is increased, it's better to wait further and get bigger studies in this particular indication to give you a definitive indication to start prophylactic HPV. Okay, cirrhosis, of course, advanced fibrosis, then you start considering treating HPV. Okay, so that part I hope I'm clear. Where you have to treat HBV as a part of indication, like DCLD, patient has compensated CLD with HBV more than 2000, advanced fibrosis, please treat. That's not here. They will tell all this is negative, still HbSH is positive, and patient also has HCV. What would you want to do? You start treatment for HCV and just monitor for the management for HBV flare. Okay, I hope GVK got the answer for this particular question. Yeah. Next is, see, a 50-year-old HBV cirrhosis has pain abdomen, CCT showing some SOL. What is the next level of treatment? Guys, there are lots, at least you might get 3 to 4 questions just completely based on the different liver lesions, okay, on a CT scan. So what you should know as a concept is, I don't know what was the option for the patients, but then you should be able to identify the lesion, you should be able to stage the lesion, and should be knowing some tables to treat, especially when it comes to HCC. Okay, so suppose I would want to see, this is a cross-sectional imaging of a CT scan. This I'm just showing to teach you guys on how to recognize a lesion. Now see, here we have a patient with non-CT scan at different phases. This is aorta. So the aorta you check because whether contrast is there or not. Now this is plain. Okay. Now you see this irregular surface of liver, so you know that there is cirrhosis. Okay. But actually, I don't see anything as per lesion per se much, but there is some mild hypodensity in this region. Okay. Now, when you have an arterial phase, see, you see that it is getting slightly, it is taking up. In the late phase, the portal phase, there is almost complete washout in this particular area. And in delayed phase, you can still see that there is a kind of washout, okay? And mild capsular enhancement. So this is a feature of HCC. So 3 things we should see. Arterial phase, there is enhancement. And in delayed phase, there is washout and capsular enhancement. Okay, this is HCC. Next is, this is the same with MRI. Okay, very similar. In MRI, again, arterial phase, you have a lesion which is becoming intense, hyper intense. In the delayed venous phases, you see that the center, there is washout, and you see that the capsule has got some form of enhancement. And this is more typical as you go toward delayed venous phase. Okay, so CT and MRI, very similar features. Don't worry much about T1 and T2. T2, always remember that bile or the biliary ducts are bright. So that is a way to recognize it. That's just for you guys to understand. Now, I just spoke about how it is for HCC, but sometimes you might have different diagnoses. So remember these keywords. If you're suspecting cholangiocarcinoma, one thing you have to know is there will be progressive enhancement in arterial, venous, and delayed phases. So slowly it starts getting enhanced. Of course, there may be other features. In cholangiocarcinoma, you have various types: intrahepatic, hilar, and distal. Intrahepatic can be again 3 more types, which can be mass forming, it can be periductal, infiltrative, or kind of intraductal. But what more common that we see inside the liver is intrahepatic mass forming. Now, these have central fibrosis. Okay, so how it generally appears is there is a peripheral enhancement in arterial phase. Okay, and they start filling towards the centripetal fashion as we go towards the delayed phase. And based on the central fibrosis, the timings change. But slowly with time, the entire tumor takes up the this one. So there is progressive enhancement. This is the keyword you should look for. When it comes to hemangioma, you know that hemangioma is a highly vascular structure. The first thing that you should know is peripherally, you will have a corrugated inner margin, which is enhanced the initial phase, and later in a centripetal fashion, it starts filling up. So there, if it will have round peripheral enhancement like this in the initial phase. You look carefully for it, it's very clear it is hemangioma. If it is FNH in a CT lesion, you look at contrast enhancements of the mass lesion and the central stellate scar that has apparent lack of enhancement. Okay, these are the clues for FNH. If you are looking at hepatic adenoma, here no, it's adenoma is nothing but hyperplasia of normal hepatocyte. Okay, that is the first step. So it is very similar to what is happening to the adjacent liver hepatocytes. Okay, and that is why it is difficult, kind of difficult to identify and differentiate with other lesions. But MRI has been good at identifying hepatic adenoma. What you guys have to know a few things is the tumor enhances irregularly with areas of increased enhancement and focal avascularity as a result of hemorrhage and necrosis. Both of it could occur within the lesion. As you go towards delayed phase, there is the enhancement tends to start decreasing, and the lesion becomes iso-intense or hypo-intense. So there is a phenomenon like washout, what occurs in HCC. On late images, usually 20 minutes, when using a hepatocyte-specific contrast agents, almost all hepatocellular adenomas are hypo-intense compared to FNH, which show homogeneous diffuse hyperintensity or iso-intensity. So the most important thing is hepatic adenoma and FNH are difficult to differentiate specifically. So it is in this very delayed phase that MRI is quite useful for differentiating these two. So just remember some clues. HCC, you guys know how to identify it now. I've just explained. Cholangiocarcinoma, now you start looking at Google on what I have told as progressive enhancement. Hemangiomas, again, see the peripheral nodular enhancement, especially in the arterial phase. FNH and hepatic adenoma, difficult to differentiate between each other, but then specifically look for central stellate scar, then it is FNH. Hepatic adenoma, you have, it's a mix, but then ultimately it becomes isodense with the surrounding tissues because it's just nothing but hyperplasia. But questions to be asked are quite rare. Okay, so you might not get in this particular topic. Next is, yeah, a CECT shows 3 lesions which remained hypodense in the portal phase of CECT. Arterial and venous phase were hypointense. So what they're telling is there were 3 lesions. They were hypodense in the portal phase of CECT, and arterial and venous phase also, they were hypointense. That means there can be different ways of approaching it. Again, in this particular question, using the previous theory, you see the lesion and try to identify. Here, there is no CT picture for me to discuss what exactly was being asked, but then probably arterial and venous phase hypointense means it is there is absolutely nothing that is happening with the tissue. So I think this question has been little, on the wrong side, where it was not clear on what was being told. So arterial and venous phase hypointense is like kind of very difficult to tell what exactly it is. So probably the question is wrong. You either can have arterial and delayed venous phase difference in enhancement. Like arterial, it lights up, and venous, it washes out. It is HCC. Arterial, you have peripheral nodular enhancement, and then as the vessel takes up, that is aorta and the portal vein, the same way it happens to that lesion, then it is hemangioma. Then, FNH, I've told you there is a central scar. Adenoma, again, I've told you how to identify them. So this question particularly, I feel is wrong and has not been recalled in the right way. The next question I would want to discuss is, A cirrhotic patient, anemia, BP is borderline. There are low platelets, but the qualitative study is normal. The tumor lights up in arterial phase. Next line of management. See, again, in these questions, some more details are not there. But what really helps you to answer the question is, if there is bleed within the tumor, what you could probably do. One is chemoembolization. More than chemoembolization, transarterial embolization is a treatment of choice. Okay. But then, as the question is half and half, what I would want to tell you is this chart is really important from Harrison, where you should know at each stage what are you going to do. And what really matters is you should be able to see the performance of the patient, then the Child-Pugh score, and then the HCC size of the tumors. Okay, these are the important things. Based on these three factors, you divide and then decide what is the treatment. Now, stage A starts from here and goes on till advanced stage. Okay, where the treatment can be based on Milan's criteria. So know the Milan's criteria. If it comes within the Milan's criteria, transplant is feasible. If it is still smaller, ablative therapy like RFA, microwave ablation becomes important. If the lesion becomes more outside the Milan's, the immediate ones that you could do is a TACE. Okay. And still beyond, where there is nodal metastasis, portal invasion, these kind of situations, the treatment gets a little advanced and you probably might have to depend on systemic therapy. And the first line of therapy has again changed recently. And this is the treatment that you generally is the first line right now. Okay. It is atezolizumab plus bevacizumab. Okay. So this is done. The next is what is not acceptable in pregnancy. A, endoscopy in second trimester. It's not acceptable. Gadolinium contrast with MRI in first trimester. Ultrasound is one of the safest. So again, we do not have option for this. What I can maximum tell you is know about few important do's and don'ts. The use of gadolinium contrast with MRI should be limited. It may be used as a contrast agent in pregnant women only if it significantly improves the diagnostic performance and is expected to improve the fetal and maternal outcome. Now, breastfeeding should not be interrupted after gadolinium administration. The ultrasound is very safe. CT is absolutely no. MRI plus or minus based on the contrast that you use. This much you should know. And when it comes to procedure during pregnancy, generally it is guarded. Second trimester and third trimester, you can safely do procedures if it warrants to be done. Okay. Yeah. Next question is, a patient wants to get screened for colorectal CA, which will not be high risk. Now, high risk is a key word because risk is again divided into average risk, increased risk, and high risk. Okay, this is the way you classify for colorectal malignancy. So now let's look at the options. Father having colorectal cancer at age of 70, which means it's a probably sporadic case. Okay. Then patient with acromegaly, patient with IBD, increased PMI. How would you want to answer this question? There are two charts that you should know from Schlesinger. First one is basic epidemiological risk factors, which are convincing and have probable evidence. Now, these are alcohol, body fat, developmental factors leading to greater linear growth. That is, you can call it as acromegaly as an example. Then processed meat and red meat consumption. Okay, these have increased risk and they have convincing evidence. Other increased risk but have limited suggestive evidence is smoking, carcinogens in the environment, food containing heme and heterocyclic amines, low intake of fruits, low intake of non-starchy vegetables, and microbial dysbiosis. Okay, so this is one thing with respect to epidemiology that you should know. And one more important chart is this one, which comes in this particular page number of Schlesinger, which classifies average risk, increased risk, and high risk. This is important. Average risk are anybody, that is, age more than 50 years with no family history, no personal history of any adenomas or carcinomas, or no personal history of IBD. Increased risk are those with personal history of CRC, adenoma, family history of sporadic CRC, and family history of sporadic adenoma. Okay, this comes to increase risk, but it's still not high. High risk is very specific. It's a hereditary condition, familial colon X, and biallelic mismatch repair DNA syndrome, and polyposis syndrome. So these are all syndromes with, of course, IBD, which gets added at the last, which are high risk for malignancies. So know this high risk, rest of them becomes less. So in this question, now knowing the theory, and when we get back here, what I feel is probably now that you are more educated with this particular topic, probably some of the options may be actually different when it came in the exam. Now, a father having colorectal sporadic malignancy makes it increased risk, but is not average, not high. Okay, acromegaly, definite chances that it has increased risk. IBD has high, obviously, because it came last at the table. BMI becoming high also is kind of increased. So it's really difficult to tell which exactly the answer for this. But then, now that you know both the tables, you would be able to answer if a similar question comes exactly or a little different. Okay. So that's why I am not specifically commenting on what the answer could be. Next is a woman, carcinoma cervix, age 35, now has CA colorectum. She has family history of endometrial malignancy. What to be tested? The thing that you should know for this is Lynch syndrome. So Lynch syndrome, what are the different malignancies that gets associated? It's a mismatch repair mutation issue where you should know that these are the malignancies that they will mention, and you should identify this combo. Endometrial malignancy, ovarian, stomach, ureter and renal pelvis, pancreatic, brain and hepatobiliary tract, small bowel, and multiple sebaceous adenomas or carcinomas and keratoacanthomas are all the different combos that they might mention to give you a clue that you'll have to look for a Lynch syndrome, that is HNPCC, and you start, the question goes towards either using Amsterdam's criteria or revised Bethesda's guidelines to evaluate for these specific genetic one. Okay, so these are the questions that will be asked on Lynch syndrome. Please go through them. Next question is, a patient has a recurrent frequent admission for constipation and obstipation since 2 years. X-ray was done, and supposedly, as per students, it was showing some dilated transverse colon and descending colon, which is probably not necessary. Riles tube and decompression, Flatus tube decompression, IV fluids, and antibiotics. Now, these two are important because they obviously, patient is sick, you might have to give them and patient is admitted. Flatus tube will decompress the colon, but a Riles tube and decompression predominantly helps a patient with, small bowel obstruction, large bowel obstruction. Usually this might not help because there will be a patent IC valve. Okay. So you may try clinically, but then among the options, I would say A is the one which probably is not essential in this patient. Okay. Yeah. Now coming to this question, a patient with chronic constipation suddenly presents with acute abdomen, fever, leukocytosis. Imaging showed diverticular disease, the sigmoid, with collection with air pocket. What should not be the next step? So, patient has a diverticulosis with a complicated diverticulitis. What should not be done? Percutaneous drainage, yes, it should be done, especially if there's an abscess. Antibiotics should be given. Hospitalization is essential. Now, this can increase colonoscopy, and this with, especially because you inflate air, it might cause problem. It's like telling there's already a mini perforation. Would you want to increase it by colonoscopy? Yeah. So the answer here is colonoscopy, which is obvious. So this is the grading Hinch's classification for diverticulitis. Go through Harrison is given well. Okay. I'm not going into depth. And these are the different modalities of management at different grades, like initial grade where you just try to, do an abscess drainage. And then as you go on down to various grades, you might have to, give a wash and do a major diversion surgeries. And then at second stage, you might have to anestomose. Okay. So this is the next question. And then there was this question: patient present with dysphagia, barium swallow was showing different time gaps at 2 minutes, 3 minutes, and 5 minutes. And which among the following was correct? Now, the barium swallow was suggestive of achalasia, timed barium swallow suggestive of achalasia, barium swallow suggestive of EGD outlet obstruction, or timed barium swallow suggestive of EGD outlet obstruction. These were the options. Probably B was the option because first thing is it is a timed barium swallow. Now, this is quite a very good entity to read about the esophageal emptying. So this is how it is done. First, to make the patient swallow in 15 to 20 seconds a barium sulfate, which is around 100 to 25 ml in the volume of 45% weight by volume. And then you take an X-ray at 1, 2, and 5th minute. So the clue here is it is timed. And this is an example of a patient where you have at 1 minute, 2 minute, and 5th minute the measurement of the column. And the column, how you interpret is this particular column is there. Now, this should become less normally, but in this patient, it's not. So it's suggestive of achalasia. So a 50% or more reduction in post-treatment height as compared with pre-treatment height on a 5-minute film is used to define as per timed barium swallow. So less than 50% height reduction is taken as failure. So suppose in the 5-minute picture, if the volume of barium reduces more than 50%, that means it is a successful procedure. If it is still remaining more than 50% of the previous one, then it is a failed procedure. Now, this is the basics that you should know. Need not go into depth. So this is a normal picture where post-procedure, you can see that from 1 minute, this column has definitely reduced more than 50% and it has gone into stomach. Okay. So that's the next question. The next question is a 20-year-old female, chronic upper abdomen pain. X-ray abdomen is showing string of pearls to the left of spine at around T12 level. What it could be? Now, most likely it is chronic pancreatitis because this is how it looks. See, you have this kind of picture. It goes across T12, L1, and L2. Okay. So this is one more picture to show a similar representation. Probably if this is what you saw or you're going to see in the next exams, you should be marking chronic pancreatitis. Next question is, a patient presents with chronic diarrhea. You have suspected a celiac disease. Anti-TTG is positive, but scope is done twice is MARSH 0. MARSH 0 means there is no feature of villus atrophy at all. So what do you do next? HLA testing, anti-endomysial antibody. C is anti-TTG, can be false positive, so it might be non-celiac enteropathy. Sorry. D is give gluten-rich diet for 6 months and then do biopsy again. See, in this question, for some reason, you are suspecting celiac disease. TTG is positive. Now, TTG being positive is not a simple thing. It is like almost quite sure that you're probably dealing with celiac disease in a suspected case. But biopsy is negative and it's negative twice. What to be done next? So if you know the algorithm from the recent up to date, then this will become easier. What you have to know is, first you do an antibody test, then you do a biopsy. If the biopsy is probably incongruent with the first test, that is MARSH 0, the next thing you do is do another antibody. Okay. And then if that becomes again incongruent, that is when you do the HLA test. Okay. Now this order, you know, then you know what to answer next. Okay. So in this question, Probably this is the part of table that you should know. There is positive TTG. So they have done a biopsy. It has come March 0. Okay. Then the next step is to perform an alternative antibody test. Okay. And you review the duodenal biopsy. If this stage again it becomes discordant, that means the antibody now becomes negative. That is when next step is HLA. Okay, so this flow chart will tell you what the answer is. Okay, so the answer would be anti-endomysial antibody. Okay, yeah. So that's about it. Let's go to the next question. This question is again not clear, but then just expect that there may be questions on HLA, DQ2 and DQ8 when you would do. That I've already told. Suppose a patient has come positive with TTG. Later you do a biopsy which is negative, and you do an alternate serology, again that antibody becomes negative because of this discordant result, but still you have high suspicion, then you do a HLA. Okay, this much if you know the order, it is fine. You can read a little more about HLAs and others, but then this should be sufficient because the question is not clear. Next question is, a young male, recurrent pancreatitis, family history in grandmother and aunts, which gene to be tested first? Now, here we know that different generations, direct generations are affected. So you're probably dealing with an autosomal dominant disorder. So you should be probably looking at A, that is PRSS1. But of late, few things have changed. Of course, we all know that autosomal dominant means it is hereditary pancreatitis, and PRSS1 mutation is the only thing which we knew so far. But the table has expanded in the recent Schlesinger. Also know that CEL-MODY8 phenotype, if mentioned, it's again autosomal dominant. Okay, so these two examples are there for telling there are autosomal dominant Mendelian inheritance for these kind of conditions. Okay, so then they may mention the other autosomal recessive ones. There are multiple autosomal recessive ones. Again, they might mention some other familial chylomicronemias, which can again be, inherited in a dominant way and can set questions in this particular direction. So the CEL, that is carboxyl ester lipase, is one more gene which you can have, which can cause autosomal dominant pancreatitis. Okay. So next question, which test will be useful to differentiate CA pancreas from an inflammatory mass? You guys should know this, that if there is a pancreas and a head lesion, MRI, CT, CA99, all of them may not be that accurate. It can just tell you there is something. Okay, but it is US with FNAC where you actually take an FNA and then see the cytology, which is most specific. So US is most sensitive test, and with FNAC, it becomes very specific too. So that is the answer that is expected in this question. Now, this is a theory. You guys read the theory later. I've just mentioned it so that it's easy for you guys to go through later. Okay. And then I've also mentioned a little lines about what is pancreatic CT protocol. So you should know that pancreatic phase is a special phase which is exactly obtained at the 40th second after administration of IV contrast. Again, a question which may be tested, and it helps in differentiating the mass that is pancreatic cancer. Okay. Not going into depth. The next question is, which is not true about HEV? More risk of infection in pregnancy. So first viewer has shown to act on HEV. C, rapidly causes progression to cirrhosis. Genotype 1 causes chronic infection. Okay, now this is the question, and it's not very easy. More risk of infection in pregnancy. We know that there is more mortality in pregnancy, but we are not sure if it causes more infection in pregnancy. But when they evaluate HEV, you get to know that good chunk of patients are actually pregnant. Okay. So first we were shown to act in HEV. It's a difficult question, but if you go through studies, so first we does have a modest act on the HEV. Rapid progression to cirrhosis, no, it would not. do any kind of progression to cirrhosis most of the time, because they are an acute infection, and only in immunocompromised patients it can cause rarely a chronic infection, and that too by genotype 3 and 4. Okay, so genotype 1 causing chronic is again wrong. So there are quite good number of options which are not true. So the options might be, not really absolute recall. So for this, please go to this particular page number 1293 from Schlesinger and go to this particular table. You guys should know that genotype 1 and 2 are what we guys get to see in India as large epidemics, usually seen in young, more males than women, and no transmission from animal to human. It's always human to human, and it's foodborne, and it is the most common route of transmission. There are no animal reservoirs. There is variable severity, and severity is particularly more in women, almost 15 to 20% mortality. And then chronic infection is not known in genotype 1 and 2. And the rest is with genotype 3 and 4, which is more common in older people, seen in non-endemic or non-epidemic areas. Here, the source is actually animals, and in immunocompromised patients, it is a real issue where it can become chronic. And it is in this chronic patients who are immunosuppressed, there are studies which have shown that ribavirin has been useful, and if some patients are not working on ribavirin, then you might try sofosbuvir. For that, I have shown you some studies which I'll show, that is here. Okay, this is a study where they say that somebody who has failed ribavirin, still it's a small subset, where sofosbuvir could probably have some modest antiviral efficacy in chronic hepatitis E. That's one thing. So you guys might wonder, like in INI SS, they should only stick to Schlesinger or something. No, in SS, they can ask you anything. Okay. Even that way, for NEET SS also, you might get some questions which can be out of bounds. So you can never stick and tell that in this exam, you will surely get only from Harrison. You will surely get from Schlesinger. No. You have these questions which has been asked from a different source. So these are the proof for you guys. Okay. So this is one more table which might help you apart from the table I showed you before about genotype 1 and 2. So some numbers that you should know is severe disease in women, and person-to-person transmission is not there. Okay, usually people think person-to-person transmission. No, it is fecal-oral route. It's more through waterborne. Okay, and genotype 1 and 2 is what you get to see in developing countries predominantly. So this is important. Next is, which among the following has least risk of HCC? Initially, maybe 20 years ago, most of the studies were telling that Wilson's disease is actually kind of protective because of some mechanism. Okay. But of late, you have enough case reports of HCC in Wilson's, but compared to these other three reasons, it may not be that major risk factor. So that is clearly elucidated in this particular table of HCC, where you have major risk factor and other liver disease, where Wilson's disease has come off in the table. Okay, so just know that Wilson's disease can cause HCC, but among the options that's given, it is the least risk. Okay, so because other options are on the upper part of the table. Okay, guys. Yeah. So the answer is Wilson's disease. Next is there is probably similar question. Patient chronically on total parenteral nutrition has recurrent complication is not which of these recurrent complication is not an indication for small bowel transplant? So recurrent dehydration, recurrent fungal sepsis, recurrent hepatic failure, recurrent central vein obstruction. Actually, all of them are actually an indication for small bowel transplantation. So what I would suggest is, know that this question has been asked. It may be slightly different. So what I would want you guys to know is go through this table once. What are the indications of small bowel transplant? Okay. The indications are when there is failure of parenteral nutrition in the form of liver disease, in the form of recurrent infection of central venous line sepsis, and which can be more than 2 times, or even if it is fungal, it becomes an indication. Central venous thrombosis more than 2 times if it has occurred is an indication. Frequent dehydration despite IV fluids. Okay, these are the options. All of them we are getting here. What probably could be the thing is for fungal sepsis, you need not wait for recurrent fungal. Even if it occurs once, it is an indication for transplant. Okay, so probably that is being tested because all of the other ones are recurrent. Even hepatic failure, I would say it's not kind of recurrent, but then, yeah, liver disease is an indication again. Now, other options, what you might know is when there is high risk of death, like desmoid tumors associated with familial polyposis, congenital mucosal disorders, ultra-short bowel syndrome in a neonate. These are important risk factors and indication for transplant. The third indication is if with high mortality or low acceptance of parenteral nutrition. So intestinal failure is an indication because of sometimes even patient might not be building for a long-term TPN, you might have to consider small bowel transplant. Next question was in an alcoholic hepatitis, when do you start steroids? The data, I don't know, but what you should know is when the MADRS discriminant factor is more than or equal to 32. So how would you measure? So all that you have to know is 4.6 times the change of prothrombin time. That is how much prothrombin time is more than the upper limit of normal plus bilirubin of the patient, total bilirubin of the patient. Okay. If you do this and this is more than or equal to 32, this is an indication. So calculate in the question and then mark that particular option. Okay. Sometimes they might ask MELD score more than what would you consider steroids? You would be considering it if MELD score is more than 20. Third question that may be asked in this particular table is about Lilly score. Know that Lilly score more than 0.45 or equal to 0.45, you would stop steroids at day 7. These are the questions we may ask, which is not suggestive of malignant portal vein thrombosis. The next question. One is diameter. The two questions on diameter. One is 13 mm, one is 30 mm. The third option is endoluminal mass. The fourth is non-enhancement. Among these options, the non-enhancement in arterial phase of CT is the best option. Again, you guys can go through theory. What are the points towards a malignant PVT is pulsatile pattern on Doppler. You have a contrast enhancement on the arterial phase, neovascularity within the portal vein thrombosis, diameter more than 23 mm, and a visible mass, a hypervascular mass near the portal vein thrombosis. These are the indications of a portal vein thrombosis having being malignant. Okay, so these are the key words that you should know. Next is a patient with acute hepatitis. What is the dietary advice? Honestly speaking, we do not advise anything special to these patients. So I would have actually marked normal diet, but then you guys might have to know that whether this option was same or little different. So these are all the things which I could find out on what to do with hepatitis patients. One, you should talk about hygiene and sanitation because it's come because of contaminated water. So avoid contaminated shellfish and meat. Avoid high iron foods and iron supplements, especially in hepatitis C, where it can cause a quicker progression of the disease. Nutritional supplements may be required. A low-fat, low-cholesterol diet may be helpful in chronic hepatitis C. Vitamin D status should be maintained adequately. Vitamin B12 again should not be too low or too high. Coffee consumption and chronic hepatitis C are where they have told that coffee consumption may be helpful by reducing the oxidative stress. So these are some data about food and hepatitis. If you have any of these points in the question that's going to come in similar topic, be ready to answer them. Okay. But diet-wise, we do not tell them much. These are the warnings that we just tell them. Okay. Next is anomalous pancreaticobiliary malunion is associated with all except it is associated with choledochal cyst, carcinoma, pancreatitis, but not with portal cavernoma, cholangiopathy. So that becomes the answer for this question. What you should know is in anomalous pancreaticobiliary malunion, you have various types. So usually what happens is there is reflux of the pancreatic juice into the bile duct and vice versa occurs leading to these things. It makes the biliary tract more susceptible to malignancies and it makes the pancreatic duct more susceptible to pancreatitis. Apart from these two, you can also lead to other biliary issues like gallbladder, adenomatosis, and gallbladder carcinomas. Okay, so these are something that you might have to know. And next question is regarding PSC. False statement is it is more common in males. It is true. Both extra and intrahepatic. It is true. It rapidly leads to cirrhosis? Question mark. Fibrosing stricture of bile duct is true. So if these were the exact options, you can mark C because rest of them you're sure. But then what is the data for this? See, always remember in PSC. Okay, first let's see CTP score. Now, CTP score for a normal, otherwise CLD patient, 2 year itself, the mortality is the survival rate is 85%, 60%, and 35%. Okay. Now, in PSC, even at 7 years, the risk is 90% people stay, 68% people are living, and 25% are living. So now this should tell you that PSC, generally, if you use CTP score, it is not a good score, and hence Mayo risk model, revised Mayo risk model came into being. This basically, this data tells you that PSC compared to other form of CLD is a better one and it does not progress that fast. That's what we can decipher from this particular data. Okay, yeah, that's about it. Next is a patient recently diagnosed with HBsAg positivity and anti-HBC core IgM is positive, bilirubin is high, and ALT is also high. That means this is an acute HBV infection. Physician followed him up for 4 months. LFTs are normal. DNA was 45,000. Okay, so DNA is still high. HBsAg is still positive. No initial HBV DNA was given. They have no complaint what to do next. The question is start antivirals in view of high HBV DNA. He still has anti-HBC positive. Third is he's in window period and HBsAg will take time to become negative. Yeah, this is probably true because it takes some more time. At 4th month, just because HBsAg is still positive and DNA is high doesn't mean that it's not clearing. LFT becoming normal itself means that patient is getting better. Okay, it might take some more time. So what you should know is, you know that chronic HBV, there are indications to start treatment. But in acute HBV infection, what are the indications to start antiviral? This becomes important. Basically, patients who have worse prognosis, like those who have immunocompromised, who have concomitant hepatitis C, HIV, older individuals, or with higher grade of liver disease, there is probably potential role of antivirals, but still there are no definitive indications. Okay. Here you can consider this. These are higher risk patients where you may consider starting. But as a general rule, patients who have severe or a protracted course in the form of raised bilirubin, higher INR, you consider giving them a short duration of tenofovir or entecavir monotherapy. Okay, it can be stopped after confirmation of HBsAg clearance. Okay, in two tests that are done 4 weeks apart. So we all would know chronic hepatitis, what is the treatment, but acute hepatitis B, do we treat? Now these are the indications for treatment. Okay, yeah. Next is which among the following reduces mortality and morbidity in acute GA bleed? I would like to tell you guys that probably the question was a little more varied. They would have mentioned whether it is variceal or it is non-variceal. This is my guess. then you can probably guess what the answer is. PPI is the best and probably has a mortality benefit, but whatever studies have gone through, there is good benefit of PPI, but when it comes to mortality, it might have not. But what you can decipher is when it reduces recurrent bleed, it itself obviously should improve the mortality. In the same way, even octreotide is also good for non-varicial bleeding also. EVL is also prevents rebleed. H2 antagonist is one among the least that was good. So what I would say is you would probably have to differentiate whether the question was mentioning about varicial or non-varicial, and then you go through the data I have put forward. Okay, usually what they have said is there was big meta-analysis containing which researched 21 randomized control trials and which compared PPI with either placebo or a histamine blocker, and it showed that there was significant or consistent reduction in recurrent bleed and need for surgery. However, there was no effect on mortality. So this is surprising. Okay, but then this is a truth according to studies. Now, when it comes to vasoactive medications, when it comes to variceal bleeding, the only molecule which has shown to have mortality benefit is terlipressin. So this is the only agent which is shown to reduce mortality, not even octreotide, not any other drug. Okay, so based on this research or the answer, probably I feel the question could have been varicial, and they might have mentioned terlipressin. If this was mentioned, then this becomes the answer to this question, because PPI again has no effect in reducing mortality. Of course, morbidity in different ways, but not mortality. Okay. Yeah. So this is the data you guys can go through once I send you the paper. Now, Gallat score is better than AFP. Yes, we know that this is a new score which has come up, which is better than AFP. There are very good data in UK which started off. Now we have good trials which has been validated this score even in US. And Gallat score, basically the question is what it doesn't have. AFP, it has age, it has gender, it has, but it doesn't have etiology of cirrhosis. So that becomes the answer. Now, Gallat itself stands for gender, age, AFP, L3, AFP, and descarboxyprothrombin, DCP. Okay. So go through about Gallat score. Of late, there are some studies on something called as Gallat US. That means when you do with ultrasound, how good it is. Okay. There are good, interesting studies you guys can go through. Post ERCP pancreatitis, which is false. Normal bilirubin reduces the risk? No. Indomethacin reduces the risk? Yes. PD stenting IV fluids? Yes. So the answer is yes. So for this, again, question has been repeated in multiple ways. What you have to know is this particular chart from Schlesinger. Know the risk factors. Normal bilirubin, young women, female gender are all risk factors to get a post-ERCP pancreatitis. Okay. So it may be paradoxical. You might be wondering why a normal serum bilirubin would cause or lead to pancreatitis, but then it does because there is increased risk of having small bile duct. Okay, there is increased risk of SOD, and the patient there are almost 30% chances of post ERCP pancreatitis in these subset of patients. Next question is, patient is having a heart condition because of which the dual antiplatelet present with upper GI bleed. You need to do an endoscopy. Which one is false? Okay. Biopsy should be avoided because the patient is on dual antiplatelet. I would not agree with that. If the patient suppose has a big ulcer or a tumor, you would do biopsies. Okay. Then this is upper GI bleed. Clopidogrel should be withheld and aspirin can be continued. Nothing to say to stop all these things. Again, what you do, you have to divide whether the procedure that you do has high risk or low risk and then decide what to do. For a diagnostic upper GI scopy, you need not stop anything. Aspirin, clopidogrel, both should be stopped. Again, it's wrong. Okay. So the best is one of this, you can go through BSG guidelines where when you do a diagnostic procedure, you can continue the therapy. But when you're doing a high risk procedure, suppose you're doing a polypectomy or you do an ERCP with sphincterotomy. These are procedures where you again look whether it is a high risk condition like coronary stents, like in this patient. And in this case, it becomes that you discuss with the cardiologist to consider temporary cessation of one of the medications with the cardiologist consultation. So if that option was mentioned in this particular scenario, that would have given us a better result. But the low risk conditions include when there is no coronary stent, then you can stop them some time later. This one. So whenever you have patient with dual stent, you feel like stopping the antiplatelets because of the procedure risk, then you discuss with the cardiologist and decide on stopping them temporarily. But if you know that the procedure is low risk, you need not do anything. You can continue. Biopsy is just a diagnostic procedure, is not an indication for stopping anything. Next is Sydney protocol for biopsy. First, know that Sydney protocol is for gastric metaplasias and atrophy. What biopsy is not taken from, the answer would be fundus. Okay. So Sydney protocol, if you look at this picture, you take 2 biopsies from lesser curvature and greater curvature of antrum. Then you take one from incisura and then from body of the stomach. So there is nothing to do with fundus. So that's the answer for the Sydney protocol. Next is regarding eosinophils in GI tract, which is not true. Esophagus is seldom having eosinophils. This is kind of true. The eosinophils are normally not found in a normal esophagus. Eosinophils are more in distal colon than proximal colon. Again, it's kind of false because proximal colon has more eosinophils. Normal eosinophils in stomach is less than 5 is true. In colon, eosinophils is up to 20. No, it can even go normally also up to 50 per high power field also. Okay, which of the following is not true? B is definitely not true. Why? Because just go through this table in this particular chart at 425 page number. You know that in the esophagus, you don't have any eosinophils. Antrum and fundus, this is the mean numbers. It is usually said that it is less than 9 and preferably less than 5. When it comes to colon, you notice that maximum is actually in the proximal colon, then you go more distally. So this is what you gather from this particular table. But then some of the texts, it's easier to remember. These are lines from Schlesinger. What you should remember is in a healthy pediatric GI tract, eosinophils progressively increase from proximal to distal intestine. Esophagus, it's normally devoid of eosinophils, but you may rarely find it in distal esophagus, especially when associated with GERD and other symptoms. The number you should know as a diagnostic threshold for eosinophilic esophagitis is 15 eosinophils per high power field. When it comes to stomach, what is said is the lamina propria has eosinophils which are usually less than 9, but preferably it is less than 5 per high power field. But to diagnose an eosinophilic gastritis, the number you should know is number more than 30 per high power field in at least 5 distinct high power fields. Okay, remember these numbers. Text you can again read it later. When it comes to intestines, what is being said is, as in small intestine, colonic eosinophil is considered as a normal constituent of the mucosa. But if the eosinophils are more than occasional numbers, they coalesce or they degranulate them, then it becomes abnormal. Okay. Normally, the numbers can go even up to 50 eosinophils per high power field, which could be normal in a colon. But what is known is the greatest in the proximal colon. Again, we can see that in this particular table, it is greatest in the proximal colon and maximum even up to 50 was found. Okay. And yeah, so when you find especially in some kids who have proctocolitis, eosinophils more than 60 per 10 high power field with extension of eosinophils into muscularis mucosa is suggestive of allergic proctocolitis. Now, these are some of the numbers with respect to eosinophils that you should know to help you manage with questions. Next is in appendicitis, we all know that when you press the left side, when you have pain on the right side, it is Rosing sign. I'm not going into detail. Then there was one question on gastric varices, but then if one of you are able to recall it or your seniors have told you, please share it with all of us. What could have been the question was questions about Sarin's classification, or it could have been on management with respect to glue injection, or different options for management of gastric varix, like what could be the diagnosis which can cause, sometimes even chronic pancreatitis with splenic vein thrombosis can present with gastric varices. Third, you might have had questions about newer aspects for managing gastric varices like US or DRTO or TIPS. These are different options, newer ones to manage a gastric varix, its tendency to bleed. Okay. Next is, what is not a normal part of fecal evacuation process? So please read about defecation and the different steps. What you should know is about the anorectal angle becomes more obtuse. So if there's no reduction, there is contraction. No, there is relaxation of puborectalis, which makes the angle more obtuse for defecation. Okay. So if you know the anatomy, these questions becomes quite easy. What you should know is, from anterior aspect, you have something called as puborectalis, which goes and relaxes to make this particular anorectal angle more obtuse. Simultaneously, all the sphincters do relax and the entire perineum descends while defecation. Okay, all of them happen in sync. So if you want some numbers, then you guys can know this angle, the anorectal angle becomes more acute and during defecation becomes obtuse. Okay, it goes up to 110 to 130 degrees. Now, in case of HCC, in recent trials, regorafenib has shown to be effective in which condition? That is, it is a third line of agent for patients who progress on sorafenib. So this is the answer. So this again, I have already shown you what is important in this table. And this is one important table which you should know. Now, they might give a question on IM Brave 150 trial, because of which atazolizumab and bevacizumab are the first line drugs now. Also know for sorafenib, there are some trials like SHARP, Reflect, and Checkmate. For lenvatinib, you have Reflect trial. So there are very few trial questions they have ever asked, but then this question is possible. In regorafenib, it is Resort. For cabozantinib, it is Celestial, and ramacizumab, it is Reach 2. Among this trial, if you want to remember, I would say that I Am Brave is one of the most important trial which you can expect in the next exam. Okay, so in the resource trial, which they have not mentioned, and it's quite simple. If you know that this is a third grade after sorafenib, if it doesn't work, what next? Then it becomes clear that it is regorafenib. Okay. Next is, regarding HCC and cirrhosis, you have a patient with abdomen distension. I'm not sure what is it, whether it was ascites or some mass. There is no HG. Albumin is 2.1, INR is 2.7, bilirubin is 5, CT picture showed HCC. What is the next line of management? A, systemic chemo supportive treatment, and RFA. You know, definitely it's not RFA because the patient condition is not good. Second, if you can do CTP score for this patient, this is 333. Already the patient is in CTP-P, and we don't know whether abdomen distension is actually ascites. With these kind of patients, based on the lesion, actually the best therapy probably would be, CTP-B and D. So patient has directly already gone into this stage. So you know that the answer is within these three things based on what you are seeing, exactly what was the mass showing, whether there was any invasion of the portal tract, then you decide. If you have just multinodular, remember multinodular without any other problem beyond the Milan's criteria, the next best treatment is TACE. Okay. So these are some questions that you should know. Next question is, I think similar questions on mass has been asked. Patient present acute onset symptoms. Imaging shows a 7 centimeter SOL with hyperdense content. Now, hyperdense content on a CT usually is a bleed. So in the liver, there was a mass and then there is bleeding. So what will you do? The best test that you have to do is If TAE was mentioned, then this would be the best. Transarterial embolization, because that will reduce the blood supply of that particular tumor mass. But then if it is big, or sometimes if the question has mentioned that there is peritonitis and there is bleed within the ascites, there is blood, the tumor has blood, then surgery would become the treatment of choice. Okay. So yeah, these are different lines about TAE. Please go through about them. And when this doesn't work, that is when you go for emergency surgical procedure. Okay. Yeah. Next is patient with anemia has macrocytosis. Which of the following are features of isolated folate deficiency? Isolated folate deficiency will have normal methylmalonic acid. So it has to be between these three options. Among this, it will have an increased homocysteine levels. Always remember that hyperhomocysteine, one of the treatment is folate also. Okay, so option becomes easier. It is A. Again, I'm not going to depth. You guys can go through the answer. It's a general medicine question. I'm not going into depth there. Next is patient has some form of pancreatitis, is alcoholic pancreatitis, then present with fever, blood pressure low, tachycardia, has a right paracolic large mass, which is probably an abscess. As per student's description, what next? Usually patient has sepsis. The next best treatment is percutaneous drainage. Okay. If this doesn't work, then you go for necrosectomy and surgery. So remember this Panthers trial, which was a trial where suspected infected necrotic pancreatitis were random to open necrosectomy or a step-up approach following percutaneous catheter drainage. It showed that there was no improvement was observed after 72 hours of VRE. So the first thing is they have compared between primary necrosectomy and step therapy. And when they show there was no difference, it means that even step-up therapy is as good as or even better than going directly with surgery. So step-up has been favored. Okay. And it also has a lower rate of major complications and mortality compared to open necrosectomy. So your option in this kind of question should be first a minimally invasive procedure. Whenever you have any abscess in the body, it has to be drained first, antibiotics, and then patient is getting sicker, then you go for next step. Okay, step up therapy. Next question is patient has jaundice. Ultrasound has portal cavernoma and compression of bile duct. By the cavernoma, what's the diagnosis? Diagnosis is very simple. It is portal cavernoma cholangiopathy. Now, portal cavernoma cholangiopathy questions, this is a new terminology, PCC. Before it was called portal cavernoma, but now we call it portal cavernoma cholangiopathy. It is a condition where you have some abnormalities of extrahepatic bile duct system, including cystic duct and bile duct, with or without abnormalities of first and second generation bile duct. You guys can read through these particular topics because these are the questions that they might ask. Okay, in this particular topic. I'm not going into depth, but then if you want me to say what it, you have to know that they can have a cholangiographic ERCP, and we do a cholangiography. There is few appearances. These patients have various treatments when they present with choledocholithiasis or cholangitis. ERCP with drainage is a therapy of choice, but then patient has further progression. Then the other options are you can go ahead with a surgical procedure that is, I will tell you what it is. It is in a phased manner. You can go ahead with portal decompression by portosystemic shunt. And third is when you can, the persistent issues of obstruction, there is also hepaticojejunostomy and choledochoduodenostomy. Now, to diagnose it, you should never do ERCP. The diagnostic test of choice in these patients will be MRCP because it is non-invasive. Okay, for diagnosis, we do not use ERCP. Okay, so even if it is cholangiography, it is MRCP that is a diagnostic test of choice. Okay, then you have two components here. Okay, one is the compression of the bile duct. is because of the pressure and ischemia. So there are two components which are playing a role in causing this form of cholangiopathy. Okay. So a shunt surgery may help you with respect to pressure, but not with respect to ischemia. So these are few things you can read these lines line by line. It might help you. Next question is patient with HBV fibroscan was done. The values were 12.5 plus or minus 2.5. How is your interpretation? I would say it is advanced fibrosis because it should be more than 15 for cirrhosis. Okay. Now, fatty liver cannot be commented by this particular thing. It needs one more entity called as CAP, control attenuated parameter. So these are all different ways of measuring hepatic fibrosis and cirrhosis. When you guys use transient elastography, which one of it is fibroscan, remember advanced fibrosis when it is more than 7.3 kilopascals and when it is more than 15, it is cirrhosis. These are two numbers which you should know. This is one more table with a slight differences. In this question, they've asked HBV, and you should know that more than 8 becomes F2 fibrosis. Okay. Next question is patient present with acute GI bleed after resuscitation. When should endoscopy be performed? As soon as the patient is stabilized, is it 6 to 12 hours? Is it 12 to 24 hours of presentation or 1 to 6 hours of presentation? Now, this question can again be divided. Suppose in the question they are asked, patient has platelet count of 1.2 or patient has known case of HBV with advanced fibrosis with past endoscopy showing varices. Then these are clinical scenarios which tells you that you're probably dealing with variceal bleed. If it is variceal, the answer will straightly go into 6 to 12 hours. Okay. If it's a peptic ulcer like bleed, you have still more time. The answer will become 12 to 24 hours. So what I would say is, there's a good paper like timing of endoscopy in NEJM. You guys can go through that. What they've told is early endoscopy. You define urgent endoscopy as done within 6 hours. It's been shown that early endoscopy done within 24 hours is recommended for most patients with acute GI bleed. However, for patients with variceal bleeding, endoscopy is performed usually at or within 12 hours. So variceal is at or within 12 hours, or if they don't give you data on that and you are suspecting other form of bleed, you should do within 24 hours. Okay, so within 24 hours. It's also been shown that emergency endoscopy within 12 hours may be associated with poor outcomes. So emergency endoscopy or urgent endoscopy is usually avoided because it has bad prognosis. So they have done a randomized control trial, that is this particular trial, where 516 patients with upper GI bleed were divided and were shown that they were at increased risk of death and further bleeding, did not find any significant difference in outcome between those who underwent urgent endoscopy, that is within 6 hours, versus early endoscopy, that is between 6 to 24 hours, suggesting a trend towards worse outcomes in urgent endoscopy group. So doing it within less than 6 hours is in fact harmful. So this is very important. A patient has upper GI bleed, you resuscitate the patient and you immediately call the gastroenterologist to do. And the gastroenterologist will tell you, "Arey bhai, wait." But there are data to prove that we can wait because it's in fact harmful. The patient has to be resuscitated well, and doing a procedure between 6 to 24 hours has been proven better than doing an urgent endoscopy. There are trials, there are RCTs to prove it. Okay, so this makes our life a little easy. So you will be tending to mark within 6 hours, but it's the answer is not 6 hours, it's 6 to 24 hours. Okay, if that option is mentioned. And to be more specific, around approximately 12 hours for variceal bleed, within 24 hours for other kind of GI. Okay, so that's about it. I think I have discussed the entire question, what I could for this particular session. Let's see if there's any question from chat box. Sir, PPI doesn't reduce mortality. they decrease need of endotherapy, variceal bleed. Okay. So GVK has told that the question is being asked on variceal bleeding. If the option you had was terlipressin, now that is the only drug which has shown to be beneficial in mortality. Okay. Sir, if a patient is in shock, then also 6 to 12 hours. That's what they are telling. From presentation after resuscitation, you can wait for 6 to 24 hours is the time that is better to do a procedure, not within 6 hours. Yes. Even if the patient has shock, exactly, you have to resuscitate the patient. There is no urgency. Resuscitate the patient, give blood transfusion, keep the patient safe for the procedure and sedation. That's what they mean. Sir, do we get this PDF? Do you want this PDF? Then yes. If you feel it's useful, then yes, I'll be sending it right away. Yeah, sure. Okay. Yeah, I was just kidding. Yes, I'll be sending it right away. I hope all of you are there in my group. Whoever are new to this particular talk, this is my phone number, 740-664-8141 for coming into my WhatsApp group where there is regular discussion on few questions. Second thing, what I would want to tell you is the April session has been discussed now. There has been a discussion of the previous, the recent paper also. Please go through those things. Okay. Yeah. Thank you, guys. It was wonderful talking with you. Some of them are asking questions. Just investigation of choice, CT or PET CT, sir. See, just CT is good enough to tell you its nature. PET CT is generally to know the metastasis load. Okay. So for just CT is enough. Anything else, guys? But however, remember, you have some other questions like Zollinger-Ellison syndrome, what you'll have to know gastrinoma and others. There it's a little different. Okay. There you divide it as loco-regional spread or a distant spread. For both it is different. For loco-regional, EUS is very good. For distant metastasis, you have gallium scan, which is good. For fecal microbiota transplantation, what is important? I feel what you're probably are asking is intestinal microbiota transplantation of IMT. Read about Clostridioides difficile, best route. Okay. There are multiple routes. You can give it as pellets orally, and you can also do colonoscopy and inject it. If a patient has Clostridioides difficile and has ileus, you might have to do a colonoscopy with minimal insufflation and inject via colonoscopy route. Okay. Yeah. Thank you, guys. Anything, please ask in the group. Sometimes I might miss answering you immediately, but there are enough students, almost close to 300 students in that group to answer each other's. Please discuss actively and good luck to all of you. Thank you.
Thank you, sir.